Welcome, everyone. My name is Amy Henriksen. I'm a registered dietitian in the Department of Medical Affairs for Nestle Healthcare Nutrition. I'm delighted to introduce today's speaker and assist with the webinar entitled Pediatric Malnutrition, Tools for Change. Financial support for this presentation was provided by Nestle Healthcare Nutrition. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented and is for educational purposes only and is not intended as a substitute for medical advice. I'm now pleased to introduce today's speaker. Welcome, Jody Wolf. Jody Wolf is a certified nutrition support dietitian at Rainbow Babies and Children's Hospital in Cleveland, Ohio. She's been practicing in the field of pediatric nutrition for 19 years with an emphasis on caring for children with neurological impairment. Ms. Wolf received a Bachelor of Science degree in dietetics from Youngstown State University and a Master of Science degree in nutrition from Case Western Reserve University in Cleveland, Ohio, where she's currently an adjunct instructor at the CWRU School of Medicine. Ms. Wolf is the chair of the Greater Cleveland Maternal and Child Nutrition Committee and is a fellow of the American Academy for Cerebral Palsy and Developmental Medicine. She was also recently invited to serve as a member of Aspen's 2014-2015 Malnutrition Committee. Ms. Wolf has authored articles and book chapters and is a frequent lecturer on nutrition-focused physical exam in the pediatric patient, and most recently has been involved in practicing, implementing, and presenting education on the new pediatric malnutrition definition. At this time, I'm pleased to hand the presentation over to Jody Wolf.
Amy, thank you so much for the opportunity to talk to the group about pediatric malnutrition. In 2010, the adult definition for malnutrition was published. And last year, the pediatric malnutrition was published by the American Society of Parenteral and Enteral Nutrition by Dr. Mehta and his group. And it was entitled Defining Pediatric Malnutrition, a Paradigm Shift Toward Etiology-Related Definitions. Aspen recognized the need for a uniform definition for malnutrition. In the world of nutrition, we find that many of us are doing things differently. And when I think about this in my own practice, and I'm not sure if you've run across this, but you might have a patient that's transferred from another facility or maybe even from a floor in your own facility, and your nutrition assessment is different than that of the other clinician. And maybe the patient didn't receive the intervention that they needed as a result. And this is a problem when malnutrition is going undiagnosed. And this is happening all over the country. And so it's very, very important that we take this work from the task force and we start using it. Now, this is going to require that we all get on the same page, and that means change. And change is not always easy. I remember when we first started using the definition, I struggled a little bit with thinking of using mid-upper arm circumference and Z-scores. I tended to think of those as more helpful in a research setting and not in clinical practice. But now, months later, I can say that I look more at Z-scores when I'm thinking of the patient, and it's rare that I'm looking at a percentile. And I get excited when I see that a mid-upper arm circumference is improving as the patient's nutritional status is improving. So what is the first step toward change? Awareness. And Thomas Kuhn, who coined this phrase, paradigm shift, said that awareness is a prerequisite. So maybe today you haven't started using the definition yet. I hope that the information can be your first step toward that change. And maybe you are using the definition or parts of the definition, but I would hope that then you could think today when the webinar is over that you're going to take this information and teach other people. Again, this is going to be a collaborative effort, and it's a very multidisciplinary, so we need to educate everyone in our facility about this. So today, as we work through the definition, and you can see the objectives there, we need to keep in mind that this definition is evolving. And as research is done, the definition will change. And we're looking forward to a joint paper that will come out from the Academy of Nutrition and Dietetics in Aspen that will further define the pediatric malnutrition characteristics. So let's get started and take a look at the development of the definition. Okay, this definition was developed by a multidisciplinary task force in 2010. And this task force consisted of physicians, nurses, dietitians, and pharmacists. and they looked at the literature from 1955 to 2011. It's important to note that the definition does not apply to neonates less than 1 month old or malnutrition in poorly resourced countries. This definition addresses undernutrition and not obesity. We know that we can have malnutrition and obesity, but this definition is specifically targeted toward undernutrition. It applies to all settings in the hospital and in the home. What is the purpose for developing this definition? Well, we need to identify malnutrition earlier. We need to know when to start our interventions, what interventions are working best. And also with healthcare reform, the Center for Medicare and Medicaid have set forth a healthcare initiative, the triple aim. And with the triple aim, we need to be improving health, improving care, and decreasing costs. And we know that malnutrition is extremely costly with increased morbidity and mortality, increased complications, infections such as infections, poor wound healing. We see increased length of stay and hospital readmissions. We also need to get a better idea of the prevalence of malnutrition, and this is very difficult when we're all doing things differently. So let's look at some of these studies. Dr. Corkins and Dr. Mehta have reviewed some of these in the past, and I think it's really important that, that we look at the prevalence that we have right now and kind of see where we're at. The Boston Children's Hospitals were kind of one-day snapshot studies where they looked at anthropometrics to identify malnutrition. The study by Dr. Secker and Gigi Boy used subjective global nutrition assessment, and you can see there that 51% prevalence of malnutrition when using that tool. And more recently, the Healthcare Cost and Utilization Project, Dr. Corkins and his group looked at this, and you can see that how low those numbers are. And this just means that we're not doing a very good job identifying malnutrition. When you look at, we know that when we take our time and look for malnutrition, that the prevalence is more, 20 to 30 and maybe even higher in some of the populations. And so we really need to take our time and use this uniform tool to define malnutrition. The definition that the task force came up with is an imbalance between requirements and intake that negatively affect outcomes. So this definition, again, when we think of the title, an etiology-based approach, this definition is looking at cause and effect. And this is very important because when we're thinking about cause, this should really help us target our interventions. So let's move on to the 5 domains of pediatric malnutrition. And this is how the authors broke down the definition. So we're going to go through each domain. Okay, anthropometrics is the first domain. And the authors remind us, that children should have weights and lengths. And this is something that we're very familiar with. But I think the important message in the paper is that we need accurate weights and lengths. And I don't know when you've done your assessment sometimes and you see that, maybe a child has a BMI Z-score of 0, or the 50th percentile, and you look at them and, they have fat and muscle wasting and they look very malnourished. At that point, we need to redo our measurements. And so I think it's important, as clinicians, if you know that the measurement is off or you see that the child has shrunk since the last visit or the last measurement, to remeasure them. And then the other thing, that we need to make sure they're accurate. And there was a study last year that Sarah Vermiglia did when she was validating SG&A in the ICU. And she found an important factor that only 16% of those patients in the ICU had accurate lengths. So again, this just stresses the importance of remeasuring. And when we're unable to get those measurements, the task force is encouraging us to use alternate height measures. So let's look at a couple of those measurements. So knee height is, this is something that I use often in my practice with non-ambulatory children. And it's a metal caliper, and it's very easy to use. Actually, you put the blade under the heel of the foot of the patient, and then the top of the caliper goes right across the kneecap. And then you'll get a measure in centimeters, and then you're going to plug that right into an equation. And I've listed the equations here for you based on age. Now that number then that you get, you can plot right on the regular growth curve and use your Z-score measurements to assess the patient. Another measurement that may be helpful is arm span measurement. And when you're doing arm span on patients, the arm span is equal to the length in centimeters. You don't need to plug this number into an equation. It's the equivalent measure of the height. I've used usually 2 people when doing this. You can use another member of the healthcare team, or sometimes just the caregiver can help you. And you're measuring from the tip of the middle finger to the tip of the middle finger of the other hand. You want to be sure that you're not using this measurement in patients that have upper extremity contractures. They need to be able to stretch their arms out so that they're nice and straight. Okay, we know that head circumference is a marker of growth and nutrition and brain development within the first couple years. And we were looking in our facility and found that we were missing head circumferences in about 30% of the patients that were under 2 years of age. So this is an area that where we really need to work on that and make sure that we have that as one of our markers of nutritional status. Mid-upper arm circumference. This is a new measurement for a lot of us as dietitians. And when it says here that it's simple and accurate, it really is. And it's found to predict malnutrition-related mortality. It's great because it's not affected by fluid shifts and edema. And it reflects a one-to-one change in body mass. So if your patient's weight's down 5%, you should see the mid-upper arm circumference change as well. And this has been really exciting to see this correlate. So when you're using mid-upper arm circumference, there are 2 steps. First, you need to find the midpoint on your patient. And you're going to look, there's a bone on the back of your shoulder, and that's the acromion process. And you want to measure down to the olecranon process, which is the elbow, and then mark at the halfway point. Now, I've included a link to a video on your handout, and it's a pretty old video, but I think it's helpful in getting some training on how to do this. But in our institution, our manager set up training with the research center, but you can also use your therapy departments and just to make sure that everyone is confident in doing the measurement. So the first step would be to find the midpoint, and your second step would be to go ahead and measure the circumference. So you want the arm to be relaxed at the side, and then you're just going to wrap the tape measure around. You want to be sure not to pull too tightly, and then you'll get your mid-upper arm circumference measurement. Now, there are references from the World Health Organization with Z-scores for 3 months to 5 years. And so that's a great measurement to use if the patients are in that reference, for the patients in that age range. And then Dr. Sancho has some good, more recent data from 2008, and that data also has Z-scores, and that could be used for patients less than 3 months old or greater than 5 years. Okay, so we've talked about anthropometrics, and now we're going to move on to growth. The authors remind us to use corrected age until 3 years of age. And this is important. The American Academy of Pediatrics clarified this for us. In some facilities, we're correcting until 2 years and some until 3 years. So they're just reminding us to correct until 3 years of age for patients because, when we're plotting them on the growth curve, this is really going to affect how we're assessing the growth. So it's important to do this. Okay, as far as growth reference data, for 2 to 20-year-olds, we want to use the CDC charts. And for 0 to 2-year-olds, we want to be sure that we're using the World Health Organization charts. The CDC 0 to 36-month charts are no longer used in clinical practice. And this is because the World Health Organization charts are based on better data. The data looked at 6 different regions, and those babies were fed optimally. So they were exclusively or predominantly breastfed, and they excluded conditions that would affect growth, and the mothers were in good health as well. Whereas when we look at the exclusion criteria for the CDC charts, the only exclusion criteria was very low birth weight babies. So in using the World Health Organization charts, we can actually say that we have a growth standard because those children were optimally fed. Now this chart is just amazing to me. When you look at the growth of these babies that were fed optimally in 6 different regions they grow similarly. And this is just amazing. I think this just shows us that with optimal nutrition, we can have a good growth. Okay, moving on to Z-scores. Z-scores tell us how far and in what direction the number deviates from the mean. So the recommendation now is to use Z-scores instead of percentiles to describe growth. The good thing about Z-scores is they're comparable across age, sex, and measure. They quantify growth outside of the percentile ranges, and they're more descriptive than less than the second or between the 25th percentile. Let's take a look at that. So here you have two baby girls, and one of them has a Z-score of less than a -2, and the other less than 5.14. Now, when we chart in our nutrition notes, both of those babies would be considered less than the second percentile, but that doesn't really tell us how much more severe the baby with the Z-score of a -5.14 is. So it's a much better indicator to use. I also find I see a lot of my patient population, they're neurologically impaired, and so perhaps they'll never be up on the growth curve. And so they may have some negative Z-scores, so maybe a -4 Z-score, and they're moving to a -3. So for me, as a clinician, it's encouraging to see that I can see a change in Z-scores, whereas before with a percentile, they would always remain less than the second percentile or less than the third, and it's not that encouraging to see that this is much better in seeing that the intervention is making a difference in the indicator here. This doesn't mean that we're going to completely get rid of growth curves. Okay, these Z-scores are created from the raw data used to make the growth curve. So when we look here, the 50th percentile is a Z-score of 0. -1 is about the 16th percentile, a -2, the second percentile, and a -3, 0.13%. And there are growth curves on the World Health Organization website where you can get the actual Z-scores. This is just a table reminding us of how the Z-scores are correlating with the percentiles. Okay, and how do we use these Z-scores to classify the severity of malnutrition? If a mild malnutrition would be a Z-score of less than a -1, moderate malnutrition would be a Z-score between a -2 and a -3, and severe would be any score less than a -3. Now this slide, we have to give a special thank you to Dr. Cho. So Dr. Cho has this tool, which is a free tool, and you can access it online. You can also download it to your phone, so it's just like an app. And I think I mentioned that it's free. And this tool has saved hours, and there are plenty of tools out there. And I've used some of the other tools with stacked growth curves, and I think this is definitely the best tool that I have found to use. And it's nice because you can enter the patient's age or birthday and the weight, height, head circumference, and it will calculate the percentile and the Z-score for you. And it will also, if you put in the gestational age, it will give you, as you can see there, the corrected age as well. Now, Dr. Cho has been very supportive of this malnutrition definition. When I had first read the paper, I contacted him and asked if he would add the mid-upper arm circumference measurements for Z-scores. So if you look over there to the right, you can see that there's an app for that. So again, if you have that baby that's between 3 months and 5 years, you can put their mid-upper arm circumference right into PD Tools and get a Z-score. So really a big thank you to Dr. Cho for all of his work. Another change that's going to be coming in the future is, given that we're supposed to correct until age 3 for the CDC charts, he's going to add that as a feature for the 2 to 20-year-old chart. So, so this really saves us a lot of time. I tried to calculate a Z-score on my own, which took a very long time. So I'm very thankful, again, to Dr. Cho for this work. Okay, moving on to the next domain of pediatric malnutrition. We've talked about the anthropometrics and the growth, and now we'll discuss chronicity. So now when we talk about malnutrition, we really want to describe how long it's been going on. So acute malnutrition would be less than 3 months. And again, that might be where you see wasting. And then chronic malnutrition would be malnutrition that has been going on for greater than or equal to 3 months. And we know, again, with chronic malnutrition, that's where our growth or our linear growth may be affected. So then you may see stunting. Okay, moving on to etiology. Again, we want etiology-based definitions. And this, again, is very important because it'll help target our interventions. So there are 2 types of malnutrition, the illness-related malnutrition and non-illness-related. And the illness-related can be acute illness or chronic disease, and typically in illness-related malnutrition, inflammation may be a component. Not in all disease-related malnutrition, but in most we're going to see some component of inflammation. When we look at illness-related malnutrition, we want to look at these different pediatric conditions and see the prevalence of malnutrition in these different populations. In discussing the mechanism of illness-related malnutrition, you can see that starvation or decreased intake, and that may be from fluid restriction or anorexia, so a poor appetite, increased nutrient losses, so maybe diarrhea or proteinuria, increased requirements. This could be from burn injury, trauma, or acetoid cerebral palsy, or altered utilization of nutrients. And this, you could see this in malabsorption, short bowel syndrome. Now, Dr. Jensen has taught us so much about the correlation between inflammation and malnutrition. And when we look at what happens, during an acute phase response or when there's inflammation or infection, it's very important to acknowledge that because you can see how it would affect our nutritional status. When those cytokines go into action, it can cause, it causes anorexia. And then we have our stress hormones that will cause hyperglycemia from insulin resistance. We have an increased resting energy expenditure, muscle catabolism, and lipolysis. And in the beginning, of an acute phase response, these things are helpful. They help us to try to get through that stressful time. But it's when the inflammation is prolonged that it becomes a problem, especially prolonged inflammation with nutritional status. And so it's really important, if it's there, that we're acknowledging it. Now, there's so much to learn about inflammation in pediatrics, and there's so many more studies in the adult world. But it's very exciting to think about what we're going to learn in pediatrics with inflammation. So what are some signs of inflammation in our patients? So when we're assessing them and we're doing their nutrition notes, we should be looking for fever and increased C-reactive protein or increased sed rate and increased white blood cell count that may indicate infection, increased glucose, or a decreased albumin or prealbumin. Okay, well, what about albumin and prealbumin for nutritional markers? What do we know about this? Well, we know that albumin and prealbumin are negative acute phase reactants, so they go down during stress. And some people may say, well, I'm going to check them both at the same time. That way I can still use them. Well, we don't really know the timing of these, when one goes up, when one goes down. These levels fluctuate and they peak at different times. The Academy of Nutrition and Dietetics has some great studies, and I put the link down there discussing albumin and prealbumin and looking at nutritional status. And, we want our nutritional markers to reflect intake. And when you look at some of these studies, the study at the bottom there, when they gave people calorie-restricted diets, the serum prealbumin did not decrease. And you would expect with decreased intake that it would. So these are important things to remember, again, when we're assessing our patients' nutritional status. The other type of malnutrition would be non-illness-related malnutrition, and this can be from socioeconomic factors such as limited resources, knowledge deficit or neglect, or it can be behavioral or environmental. Maybe there's just a limited access to food. Okay, we're going to move on now to physical assessment. And this is very important, a nutrition-focused physical exam. is part of the standard of practice for registered dietitians. And this has been validated in pediatrics, originally subjective global assessment by the work by Dr. Detsky and Gigi Boy in 1987, but more recently, Dr. Secker and Dr. Gigi Boy validated this. And again, I mentioned Sarah Vermilia and her group in the ICU validated subjective global nutrition assessment. And a component of that is looking at physical exam. And so specifically looking for fat and muscle wasting and nutrition-related edema. So what are you looking for when you're doing your physical exam? You want to look for loss of subcutaneous fat. And this can be in the orbital area, biceps, triceps, or ribs. Also muscle wasting. And this can be in the temporal area, the shoulder, the scapula, quadriceps, knees, or calves. And you can see in this picture, even this little guy is a 13-month-old, that he has lanugo, which would tell us, hey, he has an energy deficit. And that's that fine covering of hair that you get from an energy deficit. And then you also want to look for nutrition-related edema. And this can be on the top of the foot or for in non-ambulatory children in the sacral area. What techniques can you use for physical exam? Well, we can see a lot by just observing, and especially in severe malnutrition, it can be pretty obvious. But you're looking for loose skin, prominent bones, depressions or indentations, or muscular outlines, muscle wasting, flaccid muscles, or protruding bones. And then you really can learn a lot by palpating the muscles. And so if you're, let's say, touching someone's tricep, and there's a nice thick fold of tissue between your fingers, then that patient may be well nourished. And then severe malnutrition, there may be nothing there, and your fingers may actually touch. And so I think these things are helpful to add to your nutrition assessment. I thought it would be interesting to look at physical assessment and how it compares to, or how it supplements, shall I say, the Z-scores. So again, this little guy is a 13-month-old, and you can see that his weight for length Z-score is a negative 6.48. And he had fat loss in his orbital area. And you can look there at his bicep and see some loose skin hanging there. So at one point, he had some more there and had lost. He had muscle wasting in his scapula, as seen in the picture before, G-tube cellulitis. He had a very weak cry and a severe diaper rash. So you could learn a lot from looking at his physical exam. And then the anthropometric measurements would indicate that this little guy was severely malnourished. Okay, let's move on to discuss hospital-acquired malnutrition. Dr. Mehta, again, reminds us that, when patients come into the hospital, they're at risk for becoming malnourished. And they may have pre-existing malnutrition, but then we need to screen and see where patients are at, because when they come in, they have that metabolic stress that we've talked about, which can start that whole cascade of events in the body leading to poor nutrition. And so also we know that there's a lot of feeding interruptions in our patients due to testing and NPO status, and then they're just not feeling well, so they have decreased intake, and all of this can lead to malnutrition. So we need to, again, we do admission screening when they come in. It's a Joint Commission requirement. But we need to be sure that we are screening throughout the admission, that we're attending the multidisciplinary rounds, that we're really following up on intake and seeing if that's decreased, that if a child's identified at the beginning of admission as malnourished, that they remain high on your radar and that you're putting interventions in place to keep that from getting worse. We want to do serial reassessments, so we don't want patients sitting on the floor, again, not looking at their weights and intake. And then when we see this, we need to document this as worsening malnutrition. And again, we're going to talk about the etiology, why is that happening? And likely, they're ill. There'll be some kind of illness-related component and due to that inflammatory response. And again, when that inflammatory response is there, we want to include that in our definition. Okay, so we've talked about the anthropometrics, the growth, the chronicity, and the etiology. Let's move to outcomes. This is an area where we need a lot more research. Traditionally, we've looked at developmental milestones, lean body measurements, muscle strength, immune function or infection rate, healthcare utilization, so length of stay, admissions, ER visits, IQ testing, wound healing, quality of life, and functional status. One measure of functional status would be hand grip strength. And there's a lot of data in the adult world about hand grip strength and very little in the world of pediatrics. But we know that hand grip strength correlates with loss of total body protein. It predicts complications in adult patients. It predicts loss of functional status. And it's been shown to be a more timely indicator of deficit and repletion than anthropometric. So we may see a change in hand grip strength before we see a change in our anthropometric measurements. Reference values do exist for 6 to 18-year-olds. And at the bottom there, I've included a study by Silva et al. That's in the Nutrition and Clinical Practice this month. And they looked and found in their group of patients that patients that were admitted, they looked at their BMI Z-scores and hand grip strength, and they found a correlation that was significant. And so this is very important, and I anticipate that we'll have many more good studies coming out on the use of hand grip strength in pediatric patients. Okay, let's move now into our case studies. This is an 8-month-old full-term female with no past medical problems. She lives at home with her mom, 3 other siblings under the age of 5. She has WIC, and mom and grandma are the primary caregivers. This is her intake. You can see she drinks some standard formula, a couple bottles of juice or water, mixing the formula correctly at the beginning of the month, but thinning it down a little bit at the end of the month, and eats a little bit of baby food. You can see the estimated needs there. And look at her growth curve. You can see that the Z-score went from a -1 to a -3.29. And again, as after the weight falls off, you can see the length start to fall off for this little baby. And also the weight for length falling down to a -3. And the head circumference is also affected. And again, we know that in the first 2 years of life, this is when the most brain development happens. So let's look at our anthropometrics here. You can see the percentiles and the Z-scores on this table. So is this baby malnourished? Yes. And is it acute or chronic malnutrition? Well, that's where we're going to go back to our growth curve, and we're going to see, well, this has been going on for longer than 3 months. So this is chronic malnutrition. And is it mild, moderate, or severe? So again, let's look at our anthropometrics and see what we have here. The weight is a -3. Our weight for length is a -3. So that's going to be severe. Okay, and is it illness related or non-illness related? Well, we have a healthy baby who it sounds like there is no illness involved. So how do we write our problem statement for this patient? This is malnutrition. It's chronic, severe, non-illness related malnutrition. And this is related to inadequate intake, a knowledge deficit regarding appropriate feeding, limited resources as they have to use the formula at the end of the month. And our evidence would be the weight and weight for length Z-score of a -3. And also the baby had fat wasting in the biceps, triceps, and ribs. So we want to be sure and put as much evidence in our definition as possible, in our diagnosis as possible. And again, we want to try to touch on all the etiologies that may be contributing to that imbalance and causing the malnutrition, because that's where we're going to target our interventions. Okay, our second case study is a 12-year, 7-month-old male with athetoid CP. He had reflux, constipation, dysphagia, a G-tube, and a Nissen that was placed at 3 years of age. He lives at home with mom, dad, siblings, goes to school, and also after-school therapy. He eats a regular diet with thin liquids, drinks 2 oral supplements a day. He hadn't used his G-tube in 2 years. Requires complete assistance with meals. It takes about 45 minutes to eat and has some coughing with liquids. You can see his measurements here. His weight there had fallen off to a -2 Z-score. His length, a -1, and this is actually a pretty good length for someone with cerebral palsy. But his father was 6'2" also. But you can see there that he had some stunting. His BMI is a -2.71. And there are his anthropometrics. So is he malnourished? Yes, he is. Is it acute or chronic? Again, we always want to go back. How long has this been going on? Oh, yeah, longer than 3 months. So this is chronic malnutrition. Mild, moderate, or severe. So I'm looking here at my anthropometrics, and I see some -2s here. And I'm going to say that he is moderately malnourished. And the etiology, is it illness-related or non-illness-related? So this patient, I said, was both, and you can have both types of malnutrition. So he definitely had high energy needs with his apoptoid cerebral palsy, and he also had some dysphagia, but the parents weren't using the G-tube as instructed either, so that really would be contributing, and there's a non-illness-related component there. So, so we said that this was related to the increased energy requirements and not adherence with nutrition recommendations, and there's our evidence listed there below. Okay, so let's talk now then about starting this at our institution. So what should you do when you're going to start implementing this definition at your facility? I met with our chief surgeon, and he asked me some really hard questions. You know, he said, well, how much malnutrition do we have here at Rainbow? And I said, I don't know. So our manager ran some numbers, and again, we came up with 3 to 4%. We looked at 2 years, and this we know is much higher, and it just shows that, just like the rest of the country, we have a lot of work to do in identifying malnutrition. Having education and lectures, I would encourage you to, if you haven't sat with your group with the definition paper, sit down with your group and work through it and have a journal club. Do anthropometric training. Again, if there's someone at your facilities, you can do it in a research center or work with a local university. Create a malnutrition task force and identify physician champions. This is going to have to be, all hands on deck in order to make this change. And so you're going to need administrators, nursing, the medical assistants. Everyone is going to need education. And so identify your key players and involve them. A lot of times if people are involved in the process, they're going to be more likely to jump in and help remind people of the importance of keeping this going. Meet with coding and reimbursement. And I did this last week with my manager, and it's like a different language, so the way they talk, some of those terms. And so one of the things that we discovered, though, during that call is that the query that, that they're giving to the doctors when someone's identified as malnourished still had, old data on it, things with albumin, and it was more related to adults than pediatrics. And so we're going to work on a query form, and we're going to use the malnutrition definition, of course, and we're waiting for the characteristics paper. And we will work closely with our coders to do a better job at identifying malnutrition, develop screening tools, and EMR documentation is so important. And in our group, we were just building a new template, when around the same time the paper was coming out, and so that worked out well because we were able to build some things from the definition right in. But these are things these will have to be put into your template, and that'll be really helpful. So meet with your EMR team, and then see if you can build any alerts into the system, with Z-scores and mid-upper arm circumference. And another thing I would do is when you're building your note or when you're making changes, think of outcomes research, because you want things to be able to be pulled easily from your note. And so build your note or modify your note with those things in mind. This is our input side of the note. This isn't what it looks like when it comes out, but you can see we have the percentiles, but we also have Z-scores, and we're doing both triceps skin fold and mid-upper arm circumference patients with cerebral palsy. Okay, so now you have your definition and you're implementing it. And what are some important things to remember? When you identify it, you can't stop there. Don't just put it in your note. You have to alert the physician or the provider and let them know that the patient is malnourished. And ideally, this would happen in your EMR, and it would go to the physician, and hopefully that's where you're going to be headed. But you know what? Nothing takes the place of talking to the physician. And so besides, if you are diagnosing malnutrition, you're going to have interventions, and so you're going to need to discuss those with the team. Now, the good news is, with the recent CMS ruling where dietitians will be able to order therapeutic diets, that is huge for some of the delay we have in giving patients optimal nutrition. I think that's really going to help where we can get things into place sooner. But still, we want to be able to talk about the malnutrition with the team. And then at Rainbow, we have a malnutrition case review where once a month we'll meet and talk about a patient, and we'll go through their history and their anthropometrics and the diagnosis. And this has been very helpful in implementing this process. And then when you're communicating, you want to be sure and use your new malnutrition language. And so talk about the malnutrition in terms of acute or chronic, and surely, whether it's mild, moderate, or severe, and describe that with Z-scores. And now, if I'm sending emails to physicians, I'm communicating with them in Z-scores, and then I'll put in parentheses the percentiles. But I want to say, I'm really worried about so-and-so. Their Z-score went, from a -2 now down to a -3.5, and this is chronic, severe malnutrition. And communicate with this language. And even when communicate with this language when you're seeing the patients too, explain what you're doing. I tell them, there is a new way to look at your child's nutritional status. And so now we know that measuring your arm circumference shows us a lot about your child's growth. And try to, educate the caregivers as well. We really need outcomes research, and so we need to look and see with malnutrition what interventions are working, and so there's a lot to be done. So as far as implementation today, maybe you're already doing the definition, but if you're not, go back to your facility or spend a few minutes after this meeting if you're able, and really talk about why aren't we doing this, or why aren't we doing certain parts of this, and then figure out the solution. For maybe it's knowledge, and maybe you need some more education. Hopefully today helped a little bit. That paper that's coming out from the Academy of Nutrition, that's going to shed a lot of light on this for us too. So we look forward to that. And then equipment, get the equipment you need. Talk to your manager, or get what you need. Hey, if we need those anthropometric measurements, then a knee height caliper is a good investment for your clinic or for your facility. And so get what you need in order to start doing this. And tape measures are not expensive, so you could start doing mid-upper arm circumference after some training. And then as far as the time, again, the PD tools I find has saved us a lot of time. And then once you get used to doing the arm measurements, that goes very quickly as well. And again, ideally, we're going to want these measurements done at admission. And so you may not be the one doing. The dietitian isn't going to see everyone. And so this is going to be a huge educational initiative. And so we're going to have to train maybe medical assistants to do mid-upper arm circumference, and be sure that people are confident in doing the measurement, they're doing it, and then we're going to start using it. So again, identify your challenges, and then brainstorm with your group about the solutions, because it is critical that we start using this definition. That concludes my talk for today. Amy, I'll turn it over to you for questions.
Thank you so much, Jody, for an excellent presentation. And our first question comes from Christina. And Christina asks, do you consider significant weight loss or percent weight loss if it does not result in a Z-score less than -1?
Okay, that's a really good question because you want to be you want to look at growth velocity, and so this is something that will be further defined, I believe, in the Academy paper. But we don't want to wait for someone to have a Z-score of a -1. So if you see that a child is losing weight and maybe that they don't have a -1 or their weight gain has slowed, so you would expect, let's say, a 0 to 3 month old to gain maybe 25 to 30 grams a day. If they're not doing that, you don't want to wait for a Z-score to be significant. I mean, you want to identify that and have an intervention.
Great, thank you. And the next question comes from Elizabeth. She asks, is there a pediatric nutrition screening tool you recommend for inpatients?
Oh boy, yeah, that's a good question. I'm not aware of a pediatric screening tool that has been validated. I know that there's and I can't remember the physician's name, but there's a strong tool, and I can try to get more information on that screening tool for you. But we're in desperate need for a screening tool, and our screening tools should really have this new malnutrition criteria built into them. And so I see in the future that hopefully we'll develop screening tools that include this criteria. So it could be that if there are screening tools out there that they may not apply to this new definition. I think that in different facilities, we may have tools that we use. Like we have screening questions when a patient comes into Rainbow to identify that they're at high risk. But our screening right now does not incorporate, the malnutrition definition yet. So that's something that hopefully will come out of this, of using this definition as more uniform screening tools.
Thank you so much. Our next question comes from Amy, and she asks, how long does it take to see changes in mid-arm circumference? How often would you measure it inpatient? Once a week?
Yeah, so I'm on the outpatient side of things, but I work, with our inpatient team as far as communicating, and they're doing mid-upper arm circumferences on the patient. But I would recommend doing a mid-upper arm circumference when you're reassessing the patient, for sure. We do it at every visit, and I would. Well, it'll be interesting to see what if this comes out in the characteristics paper, because I don't feel like there's any great studies that would show how often to check this. But I would say when you're getting measurements, you should also get a mid-upper arm circumference. Now, I don't think, how sometimes when babies come in with malnutrition, you might get daily weights. I don't think we need to get a daily mid-upper arm circumference. But I would say maybe weekly. But I think we're going to want to wait and see what the Academy of Nutrition says. That's a very good question.
Thank you very much. Our next question comes from Erin, and she asks, do you run the risk of mis- or over-diagnosing mild malnutrition based on Z-scores of -1 to -1.5 for children whose true genetic potential puts them at the 3rd to 10th percentile on the growth chart?
That's another excellent question, and I think that using that Z-score of a -1, that is not the only parameter you're going to be using. So that might flag you to take a closer look at the patient. So if I had a patient with a Z-score of a -1, I mean, I'm going to be asking questions about their intake. I'm going to be looking at their growth trend. Were they higher and now they've dropped down to a -1? But you're right, and that we may have some kids, and that's their normal genetic potential. Now, with subjective global nutrition assessment, they have you looking at the parents' growth as well, and that's something that we want to keep in mind as clinicians too. What's their growth potential? But I think that it's better to to have that -1 there, knowing that, hey, this may be normal, but it's going to clue you in to looking looking closer at that patient. And again, if if some of the other parameters that you're looking at or characteristics lead you to diagnosing that child with mild malnutrition, that's okay, because if they're readmitted or they come back and that's on their record, then that child is now on the radar. And so so you're going to it's going to cause you to take a closer look at the child. But again, you're never going to want to use just the Z-score to say that the child is mildly malnourished. Look at the whole picture, just like you wouldn't look at just a less than the third percentile to make that definition. You're going to look at the overall trend and the intake.
Great, thank you so much for that answer, Jody. Our next question comes from Ellen, and she asks, you briefly mentioned a patient may have length growth stunting due to chronic disease. How would you approach a patient with Z-scores of less than -2 for weight and length for age, but proportional weight for length?
You really need the trend. You really need to know how the child was growing before. So if they were in proportion and they had always been tracking along the -2, then they're in good proportion, and you're going to want to look at everything. You're going to want to look at their intake as well, and their medical diagnosis. But you also want to be sure that is it disease-related malnutrition? What's the reason why this child is stunted? You always want to make sure that that we're not missing some medical reason. But I think the danger lies in not having the trend, the previous measurement. So if you don't have those, hopefully you can get them. Now with EMR, that makes it much easier. Hopefully you can, get that from, but if you don't, you might have to call the pediatrician's office and get growth records and kind of see, is this child stunted, or is this how they've always been? And again, how tall are mom and dad?
Thank you for that. Our next question comes from Sarah, and she asks, is the mid-arm circumference still recommended for renal patients with edema?
So my understanding is that the good thing about mid-upper arm circumference is that it's not affected by edema or fluid shifts in the upper arm. Now, I'm not a renal dietitian, so I have to say that I'm not sure what the literature shows on that, but I do know that that's one of the positive things about the mid-upper arm circumference. That's one of the reasons it would be a better indicator than weight per se.
Great, thank you. The next question comes from Susan. She says, do you know of a good resource for training dietitians in performing a pediatric physical assessment?
That's a great question. Dr. Secker actually has an excellent article that was in the Academy's journal, and it's the how to perform subjective global nutrition assessment. And she has some great tables in there that talk about physical exams, and so I would really recommend, again, that article is by Donna Secker, and it really has the how-to and a really nice table about physical exams.
Great, thank you. And the next question comes from Holly. I saw that you didn't use the cerebral palsy growth chart for your case study. Does the malnutrition Z-score apply for cerebral palsy growth charts as well?
That's an excellent question as well. And I do use the cerebral palsy growth curves when I'm looking at the kids. They have growth curves from 2011 that have the gross motor function scale on them. And those are helpful, but the problem with those are that this is what we want to keep in mind anytime we're using those specialty growth charts. Now those are very nice growth charts in that they have a very an excellent sample size, and it's based on the patient's activity level. So if you use the GMFS1, the patient's walking, and the Ford, they're in a wheelchair, and so that's nice because you would expect the growth to be different. But what we have to remember when we use these charts is that not all those patients necessarily had good nutrition. And so we may have malnourished patients in that sample size. And so again, at that point, those tables become a growth reference and not a growth standard per se. The other thing about using the CP growth curves for malnutrition is that we don't have the LMS parameters. And I guess I'm not, that's not my strong point, statistics, but we need the smoothing technique that we need in order to calculate a z-score. And to my knowledge, we don't have those for the CP growth curve, so we couldn't calculate a z-score easily using those growth curves. So I really I've always used, anytime I have a specialty growth curve, I'm always using both growth curves, and I've really found that this has been helpful, even though a lot of my patients aren't on the growth curve, is still using those z-scores. But that's an excellent question about the CP growth curve.
Well, thank you so much, Jody. That was excellent. Unfortunately, we're out of time, and we don't have time to take any more questions. I'd like to thank everyone for your participation today, and especially Jody for an excellent presentation. On behalf of the Nestle Nutrition Institute, we hope that you found this information valuable to your practice, and enjoy the rest of your day. Thank you.